there's a chance that it's hidden for some reason.
Okay.
So I'll look it up.
Okay. Thank you very much.
Okay, we're going to get started. Okay, I guess you just had a final for epidemiology. I'm sorry. Well, it's over. You guys did it. Aren't you happy it's over? It's behind you. Yay. Okay, someone in your class, thank you for letting me know my lecture did not upload, but it's there now. And I don't have my speaker on. Whoops. Okay, so can everyone see the PowerPoint now? Okay, good. All right, we're going to get started right away. And I apologize that I'm starting with some recall, but don't worry, you don't have to recall. I'll fill in the blanks today. Okay, so one thing I wanted to point out is this is not truly a recall, but just a shout out that I don't think I said this out loud. And that is that we talked about some of the beta-lactams being absorbed orally, and the main one that we said was amoxicillin. So penicillin G is the prototype of that family, and it is not bioavailable when given orally. So we're never going to be using penicillin G or benzyl penicillin in an oral format. And I just wanted to make sure I actually said that because I don't think I did in lecture. So the only route of administration there is then intravenously or sub-Q or IM. Okay? Now this part, I know you probably have not reviewed this material, but if anyone can remember, I'll be super excited. All of the beta-lactam antibiotics share the same mechanism of action. They inhibit, yay, by binding to penicillin binding proteins. I'll fill in that specific part for you today. And they prevent those NAG-NAM cross-linkages from forming. And then I told a weird but true story about a pony dying from trauma following a procaine reaction. So procaine, penicillin G, but it was a reaction specifically to the procaine molecule. And then the other things to recall are that at the very end of the lecture last time we talked about beta-lactamases, and that beta-lactamases are bacterial enzymes. So they're of bacterial origin, and they inactivate the beta-lactam antibiotics. They protect those beta-lactam rings, or they eat up those beta-lactam rings. And then the beta-lactamase inhibitors are potentiating agents, right? So they protect the beta-lactam ring so that antibiotic can be useful. Okay? So here are all the answers filled in case you didn't get them when I said them. I know I mumble a little bit through my mask, so if ever you can't understand me, let me know. And we'll move on. So I'll make sure I post the one with the answers as well, but this is just a good example of some of the things that we should know at the end of this course. So basically, where did we leave off? Well, I think we left off with talking about the other subset of beta-lactam antibiotics, which are the big class of cephalosporins. So nicely, these also work by inhibiting cell wall synthesis. They, in terms of their spectrum of activity and some of their physiochemical properties, we'll talk about those in a minute, but they are time-dependent antibiotics. So you need to maintain a concentration at the site of infection above the MIC of the pathogen for the entire dosing interval, or as much of the dosing interval as possible. And the first generation are most like your classic penicillin G. So their spectrum of activity is generally gram-positives and anaerobes, okay? So narrow spectrum for your first generation of cephalosporins. For third generation cephalosporins, they're more broad spectrum. So they get gram-positive and gram-negative aerobes, and then some anaerobes as well. And then your fourth generation are more specific to get more gram-negative enterobacteriaceae, so some of the E. coli and other nasty gram-negative organisms. And they do still get some gram-positives, but they lose some of their gram-positive efficacy, okay? So they're more towards the gram-negative side. So that's just the best way to kind of categorize them in your head, is first generations are just like Pen-G, narrow spectrum, gram-positive, and some anaerobes. Third generations are the most broad spectrum, and then fourth generations are kind of more specific for some gram-negative bacteria and certain gram-positives. The prototypes of these drugs, so the types, the actual drug names in the first generations, we're going to use these in clinics, so they're important to know, are cephalexin and cefazolin. Now there are more in that first generation class, but I'm not going to try to make you memorize the long list, but the main ones that we see in clinics. So cephalexin and cefazolin. And if you guys were going to guess, thinking about a use for a first generation cephalosporin, which has gram-positive activity, what sort of infections would you want to treat with that? Where would the infection be, and what kind of organism? An example of... Yeah, that's a perfect example. So your skin infections and Staphylococcus, a gram-positive cocci, so good. And then third generation, more broad, so cefpodoxime, ceftiofur, and cefovizin, those are underlined. So there must be something important about them. Well, the main things are, those are the main ones we use in clinics, okay? So if you had to only think about 3 third generation cephalosporins, those would be the 3 you should really know about, and then ceftazidime, ceftriaxone, and cefotaxime you might come across, but it's not going to be your day-to-day use of a third generation cephalosporin, okay? For fourth generation cephalosporins, the main ones again are cefepime and cefquinome, and again, we're not going to have to remember those, just know that their spectrum of activity is going to be different than your third generation cephalosporins. And there's probably fifth, and by now, sixth, seventh, eighth, we're not going to have to go through all of those during this class, but just know that they exist, because if you do come across them, then you'll have some background information to understand what that means, and you'll know that there's probably a different spectrum of activity or something different about that group. One little thing to point out is that the first generation, there's a FA in those names, so they always have a PHA or a FA. So those, if they were not listed this way, and you just saw how they were spelled, by spelling alone, you can kind of put any of this first generation cephalosporins in the right category by seeing that they have a FA or PHA in their name. The third generation are all the other ones, and you don't have to really recall the fourth generations, even though I said 2 to recall here. Okay? The route of administration for these, it varies. There are some good oral examples in this class or this group. So cephalexin can be given, administered orally to animals. Cefpodoxime, cefepime, and cefquinome are all oral antimicrobials. And then the ones that we can give parenterally, and really only can give parenterally, which means injectable, sub-Q, IV or IM, are cefazolin, ceftiofur, cefotaxime, and cefovicin. So cefovicin is that Simplicef drug, and we're going to talk about, or Convenia, sorry, not Simplicef, Convenia, and we'll talk about that in a minute. So again, the disposition, so kind of the properties of this drug are similar to penicillin G in that category, in that class. But what's otherwise interesting is even though they're very polar and they have some degree of protein binding, as you increase in generations, you get slightly more lipophilic properties in some of those drugs. So some of the drugs like ceftazidime and even ceftiofur are slightly more lipophilic than your typical penicillin G. These drugs are excreted unchanged in the urine, so when we see that as one of the properties, if a drug is excreted unchanged in the urine, that typically will tell you that there's going to be high levels of that antibiotic in your urine. How could that be beneficial? Yeah, for UTIs. So you can reach much higher minimum inhibitory concentrations for pathogen in urine with concentrated antibiotics, because that's where the body's getting rid of them, than you could for the same pathogen in the bloodstream or in the tissues. So you're getting extra, higher concentrations of antibiotic in that actual fluid than you would be elsewhere in the body. Does that make sense to everybody? Okay. There is some active tubular, renal tubular secretion. And one other important thing to note is some of these drugs get metabolized really rapidly in the serum or plasma into active metabolites. And the main reason that this is important is really only if you're reviewing the literature and looking at plasma concentrations of these drugs. Because if you're looking at plasma concentrations of ceftiofur, it's going to decrease really, really rapidly, but it's only because it's getting metabolized in the plasma to desfuryl ceftiofur, which is an active metabolite. So when people are doing pharmacokinetic studies, they really need to be studying what desfuryl ceftiofur is doing as well, because that is also providing an antibiotic effect, okay? So the story that goes along with that is we used to give foals Naxal, which is ceftiofur sodium, 4 times a day at 10 milligrams per kilogram. Some people even went up as high as 20 milligrams per kilogram, because when they did the studies looking at the parent drug, ceftiofur, it looked like it was just going, so rapidly out of their body through urinary excretion that they thought they needed to give it more frequently and a higher dose. But actually, they needed to be measuring the active metabolite. And so once they did that, the dosing intervals changed completely. And now we give ceftiofur to foals at 5 milligrams per kilogram, so much lower dose, only twice a day IV. Okay, so that's important to kind of think about. And I'll point out if there are any other drugs like that that you need to look at the active metabolite. Okay, so for toxicity, this is going to be exactly identical to the other beta-lactam. So we can see anaphylactic allergic type reactions when we administer these drugs. We can see hypersensitivity reactions, and mainly we're talking about things like immune-mediated hemolytic anemia or thrombocytopenia, and these things don't happen very commonly, but they can occur. And then we're always worried about GI upset, especially in hindgut fermenters. And this can happen when the drug is given IV, sub-Q, or of course orally, but we don't really have any examples of oral cephalosporins to give in adult horses, okay? So a contraindication would be any animal with a known hypersensitivity. Okay, so this is a notable and clinically relevant point down here, which is that cefovicin, which is that Convenia, actually increases the concentrations of things like carprofen, furosemide, doxycycline, and ketoconazole, because it competes with those drugs for protein binding sites. And so it's the free molecule of this drug that's active, but it's highly protein bound. It will push other molecules off. So you need to think about that if you're giving this in combination with some other drugs. But mostly this is how it's able to stay above the MIC of the pathogen for a prolonged period of time with only one single injection because of the high protein binding in the patient. So the elimination half-life here is really long. It's 5.5 days. And that makes it a really nice drug to be able to give to your small animal patients, one injection, and then you've got multiple days of antimicrobial coverage without having to pill that animal repeatedly or stick that animal repeatedly. Okay. Okay, so now I'm going to briefly touch on this here because I think Dr. Cordeel will go over this a little bit more. But we're going to talk when there are important food-producing species, either regulations or rules, we're going to point them out throughout this course as well, because this is something that will definitely come up on board. So even though the class might not be that interested in food animal medicine, this is important for you as a veterinarian to understand these regulations. So the cephalosporins are pretty highly regulated. And now, when I was a vet student, they had just issued a strict regulation for using cephalosporins in food-producing species. But that's been upgraded. So initially, there was just no extra label drug use. And now we have really strict prohibitions on using cephalosporins that are really guided by using exactly the drugs that are labeled for food-producing animals, so especially when we're talking about cattle, we can only use ceftiofur, and you can only give it at the labeled dose and duration. There's no extra labeled drug use anymore for these drugs. And the main reason why this becomes important and why drugs become regulated in food-producing species at all is either they're of critical importance to treating some sort of infection in people, or the drug residues could be toxic to people. So those are the main reasons why drugs get prohibited in food-producing species, and that makes good sense, I think. And so in this particular instance, the cephalosporins are so heavily regulated because they are such important drugs for human medicine, okay? So cefepime is the only one where extra label use is okay. And that is a drug that's actually given intramammary, so it's not even given, parenterally in those cases. It is still okay to use extra label drug use in minor food animal species, and that example of those are sheep and goats, okay? So I just provided a little breakdown here of some of the drugs that we use and their generations. Gave you the formulations, and where it says parentheses, the VL is veterinary labeled. So not all of the cephalosporins that we use have a label in veterinary medicine, but the ones that do are listed here. So cefpodoxime is the simple cef I kept saying. That is veterinary labeled. There's cefitabs that are labeled for oral administration in small animal. And again, you guys already brilliantly said this is a good drug for skin infection, and so some of the indications are listed here all the way on that right-hand side. It's also a good drug to use for perioperative antimicrobial coverage for clean procedures, so things like elective arthroscopy, where you're most worried about getting contaminants from the skin at your surgical site. We have second-generation cephalosporins that we're not going to go over in detail because we really don't use any of them. And then the main third-generation cephalosporins that we need to know are ceftiofur, cefovizin, and then to a lesser extent ceftazidime, cefotaxime, and ceftriaxone. And those three, again, there's no veterinary label for those three right now, and so really focusing on ceftiofur and cefovizin are the most important. So now what you can see over here is that there's, that oral example, the cefpodoxime is an oral drug, and then the rest of them are given parenterally, so either injectable sub-Q, IM, or IV. And the ceftiofur is also broken down three ways. So there's ceftiofur sodium, which is Naxal, so that's the salt of ceftiofur. It basically looks like a yellow liquid that's clear. There's ceftiofur HCl, which is Xanil, which is compounded with hydrochloric acid and looks more like a thicker yellow liquid also, but it does not go intravenously. And then ceftiofur crystalline free acid, which is Exceed, and that is a very, very opaque white to tan formulation that is only given intramuscularly or subcutaneously. And exceed, there's a specific area that you give it in cattle at the base of the ear or at the, in between the arteries of the ear, so either on the ear pinna or at the base of the ear. And you have to be extremely careful with that drug as well, because if that drug goes intra-arterially, those cattle can drop dead as well. So again, making sure you're not going to hit a vessel, especially not an artery, is really important. And these have specific label claims of what they're to be used for. So we're not going to have to memorize all of that in this class, and this is especially important for food-producing species where there are certain indications that you can use these drugs for, and there's also certain ages that some of these drugs can be used in as well in cattle. And then cefovizin, as we said, is convenient, and the big thing there is that you can give an injection once and have multiple days of antimicrobial coverage, and that's due to the protein binding of that drug in the patient that provides kind of a slow release over time of that drug to have concentrations over the MIC for the entire dosing interval. Okay? Okay, so then we're going to just skip to the last part of our beta-lactam talk, which is the carbapenems. And you should really be not using these on a day-to-day basis, but have an idea of what they are and what the importance is. They are in the beta-lactam family, so they inhibit cell wall synthesis. They have a very broad spectrum of activity. They're bactericidal and time-dependent as well. The prototypes here, imipenem, which is the one that you're going to encounter in veterinary practice, meropenem and doropenem, and then these can be potentiated as well, so they can get a potentiated agent to protect their beta-lactamase rings, and here, or their beta-lactam rings rather. And here, psilostatin is the potentiating agent for imipenem. Okay, so that's the beta-lactamase inhibitor here. The routes of administration are only IV, IM, or intrasynovially. These have very poor oral bioavailability. Okay, you cannot give these orally. And you should be thinking, should I be giving this at all? So this should never be an empiric choice. It's never going to be your first line. This is only going to be if you have an established infection and you have an isolate that is not sensitive to any of the other drugs that you have available to you, and you have evidence of treatment failure on the empiric therapy that you selected. And the importance right there is that if you've already started the patient on a therapeutic protocol and you get your culture results back with a susceptibility, and it looks like it's only susceptible to imipenem, but here you are treating the animal successfully with your already established therapy, that would not be an indication to switch to this new drug, if that makes sense. If you had treatment failure and you had, the animal was febrile and had signs of systemic inflammation and disease, that's a different story. And in our hospital, we actually need to get approval by a committee to use drugs like this because they are of a critical importance in human medicine. So these are kind of the last guns that we have to treat really resistant infections in hospitalized patients in, people. So similarly to the other beta-lactams, it's nice, they're also metabolized, and then they're metabolized though to an inactive form in the renal tubules, which is important to know. So renal excretion, but not very good for UTIs then if they're not active, right, in the urinary tract. The toxicity is that we see CNS signs sometimes in small animals, and then you could also have GI upset and all the other things that we see with the other beta-lactams, okay? Again, a specific indication is treatment of infection that's resistant to your first and second tier antimicrobials, so your more commonly used antimicrobials, and usually have to do this with approval and show that there's been treatment failure. And I think I've just about hit this over the head hard enough, but these are critically important, right? So we're not using these on a day-to-day basis. We actually do see emergence of resistant Enterobacteriaceae to these drugs already, so it's just highlighting how important it is to reserve those drugs that are more broad spectrum and specialized for nosocomial infections in people. So in this particular case, there would be contraindications of giving this drug to a patient that had meningitis or some other neurologic deficits, because a toxic side effect could also be CNS signs, And then that could be very difficult to understand if we're got worsening of our underlying disease or if we now have toxicity from the drug, right? Okay, I don't have any break slides, but we're going on to aminoglycosides. So we're saying goodbye to the beta-lactam class. It's big. The main things you need to know are the penicillins and the cephalosporins, and that we don't use imipenem as a first-line drug, okay? Moving on to aminoglycoside antibiotics. So this is a whole new mechanism of action. They inhibit protein synthesis via 30S ribosomal subunits, and they are oxygen mediated. So for them to be able to be effective at breaking up the cell membrane, they need oxygen. It's an energetic step. And so if they need oxygen in the environment to be able to be active, in what environments do you think they can't do much in? Anaerobic. So they are no good against anaerobic bacteria. So these are concentration-dependent drugs. They are unique in that they are bactericidal. So as part of their energy-dependent step getting into the cell membrane, they kind of break up that membrane and cause leakages as well, and those cells rupture and die. That's different than most of your protein, your drugs that inhibit protein synthesis. The other drugs that inhibit protein synthesis all tend to be bacteriostatic, okay? They're narrow in terms of their spectrum of activity. So they're wonderful against gram-negative bacteria and aerobes, but we're not going to get any anaerobes or any special bacteria with them, and they will get select gram-positive cocci. So really we're talking about staphylococcus here, okay? Specifically staph. The prototype in this class is amikacin and gentamicin. Those are the two ones that we use parenterally, so that means injectably, IV, IM, sub-Q, and then neomycin and these others, kanamycin and tobramycin, are usually used in topical preparations or otic preparations or ophthalmic preparations. Streptomycin is an old member of the class, old, and we don't use it anymore because it's extremely nephrotoxic, okay? So it's out. But it's like a classic aminoglycoside, and it's important that you know about it because you want to know where it fits in with all the other drugs. If you see it in literature, or if you see someone using it in practice, it would be like an old school kind of thing to use. So the routes of administration here is there is no oral bioavailability, so everything we do with the aminoglycosides is given either intravenously, as we said, intrasynovally, or topically. And the one exception here is we will give neomycin orally sometimes, but only to have a topical effect in the GI tract. So there's no absorption of the drug, but local activity of the drug in the GI tract to change some of your flora. And that is not something we usually do to treat a bacterial infection, but sometimes to help treat other conditions. And the main one I can think of is hepatic encephalopathy in horses. So when their livers are in failure, some of the bacterial population in their gut will produce urea and have increased ammonia concentrations in their bloodstream, what a normal liver could deal with, but an abnormal liver can't. And so sometimes we'll give neomycin to change that bacterial population, decrease the blood ammonia concentration to reduce clinical signs in that patient. Does that make sense to everybody? Okay. These drugs are very, very highly polar, so they do not cross cell membranes or cell walls. Everything that they do is through kind of either pores, so water-filled pores to get into cells, and then, like I said, there's that oxygen-dependent energetic part of the pathway for them to actually get into bacterial cells. They are inactivated in purulent material, so they don't work good in acidic environments or where there's a lot of, just organic material around. And the main way that they are excreted from the body is through renal excretion, but this is through a process where they actually have to be taken up in the proximal renal tubules and then secreted again. So there's a really high risk of nephrotoxicity in this particular class. Before we get into toxicity a little bit more, we'll just mention that, again, the main specific indication is if you have a specific gram-negative infection, these drugs are good against the Enterobacteriaceae class, and they also are important in providing polymicrobial coverage in combination with one of your classic beta-lactams like penicillin, okay? Or a first generation cephalosporin where you've got narrow gram-positive and anaerobic coverage, and you need to add an aminoglycoside to get more gram-negative coverage. Does that make sense? This is something that's routinely done in large animal, but would be not really. Aminoglycosides are rarely used in small animal medicine. And the main reason is because they are so nephrotoxic. So they are nephrotoxic, again, because they're going to accumulate in the renal tubular cells before they're secreted. They're also potentially ototoxic. And the main things we see with that are vestibular signs in cats getting oral as in ear oral treatment. And then auditory problems in dogs getting that sort of topical therapy. And we can also see neurotoxicity in the form of neuromuscular blockade. And this is more likely to occur if you're giving an aminoglycoside with another drug that blocks neuromuscular junctions, or in a patient that's under general anesthesia, because there is some degree of neuromuscular junction blockade during anesthesia. And this can happen even when you give the gentamicin or aminoglycoside in a lavage fluid. So it's been reported in people where they put gent in the lavage fluid, okay? Not as important as a side effect for our veterinary species. The main ones to know are nephrotoxicity and ototoxicity, but I just remembered non for boards, and I think that hopefully will help you as well. So NON, nephrotoxic, ototoxic, neurotoxic. For contraindications, okay, this is pretty easy and logical. So dehydration and hypovolemia and renal injury or insufficiency. If you know that those things exist, this would not be a good drug for those patients. So if you know that the animal is likely to either have a pre-renal or renal azotemia, some other hit or injury to the kidney is going to have to work very hard to get the aminoglycosides out of it. And so this is just another example of where you could have two insults to the kidney and make that patient much more likely to have kidney injury or kidney failure down the road. There's a voluntary ban on using aminoglycosides in food-producing animals, and if it is used in any way parenterally, there's an 18-month meat withdrawal. And if you were to do this, you would really have to have the producer sign away, that they would never put this animal in the food chain and all of this other stuff. So we just don't use aminoglycosides in food-producing species, and we go as far as to really not use them even in small ruminants, okay? So I just wanted to point out that the beta-lactam and aminoglycoside antibiotic family, as I kind of alluded to, are a good example of synergism, and I did mention that in that first lecture, but here they work together to get into the cells. They both, disruption of the gram-positive cell wall by the beta-lactam will enhance an aminoglycoside's ability to access that inner cell membrane and actually aid in killing of those bacterial cells. So together, they can do more damage to bacteria than by themselves. So they're synergistic, and their specific indication is for polymicrobial infections, and that's not something we see that all that uncommonly. A good example in a horse is bacterial respiratory disease and pneumonia. Okay, so now I have a little clinical conundrum to present. This is an example of a septic neonate with an infection that is sensitive to amikacin, and it's clinically doing well. So it's not febrile, it's really responding great to your antimicrobials. But you've noticed that the creatinine concentration has increased from 0.8 mg per DL to 1.6 mg per DL in just 24 hours. And so that's basically a doubling of the creatinine concentration in a very short period of time. And there's no other changes. The foal is still nursing well, still urinating appropriately, but you have this increase in creatinine. So you don't think it's from dehydration. And that really worries you because it's on amikacin, and amikacin is directly nephrotoxic, right? So you really want to keep administering this medication, but you want to reduce the risk to the kidneys. Which of the following would not be a logical approach? So I think that we probably skimmed over the fact that we are giving this drug once daily. This is a concentration-dependent drug. I might have just said it out loud and just moved on, but we've only talked about time-dependent drugs so far in terms of giving you examples of time-dependent drugs, which you have to do multiple time-a-day dosing, usually, unless you like sulfovicins protein-bound. But with amikacin, all we're trying to do is get one time during the day where the peak concentration is really high, so 8 to 10 times above the minimum inhibitory concentration. And then we want it to drop down and have a low, low trough, because that's when it's going to be less nephrotoxic, is when we're down at that trough level. We want to get a nice low trough. We don't want it to be hanging out in high concentrations in the patient for a very long time. So if we look through these choices here, would it be logical to administer IV fluid therapy? Absolutely, because then you're going to diurese the patient, help increase GFR, help move these metabolites and these drugs through the kidney. So that's one thing that's reasonable to do. Measure trough concentrations. Yeah, let's measure trough concentrations and make sure that we're not giving the next dose while the plasma concentration is still too high in the patient. Extend the dosing interval. I don't think that'd be a problem if we're doing that with measuring the trough concentration at the same time. That way we could really get an idea of maybe we need to give the drug only once every 36 hours. The one that really doesn't make sense here is to split the dose and give it Q12 instead of Q24. Because all that is likely to do is to expose the bacteria to not a high enough concentration of drug to be effective, and to expose the patient to a longer time of seeing a high level of that drug in its body. So the last one here doesn't make any sense for trying to reduce the toxic effects of this this peak or concentration dependent drug, okay? Does that kind of make sense to everybody? And so you're not going to do the patient any harm by not giving the drug every 24 hours, especially if the trough isn't even dipping down low enough in that 24-hour period. Okay, so that just helped us kind of take a little quick mental break to move on to our next class, which is the tetracycline antibiotics. And I like to have these kind of paired, like one after the other, because I try to cluster them by mechanism of action. So these are similar in that they inhibit protein synthesis via the 30S ribosomal subunit, but they are bacteriostatic. But if you're just being very pure, we're talking about inhibiting protein synthesis with the same area of attachment for this group of drugs as we were for amikacin or the aminoglycosides. So right there, I know we get bogged down in these mechanisms of action, but again, this is one important thing to remember, because you wouldn't want to use two drugs that do exactly the same thing, because all they're going to do is either inhibit each other, compete with each other, but unlikely to be very effective, and might give the bacteria opportunity to enhance how quickly they become resistant to those, to that particular mechanism of action. So again, these are largely time dependent, so you want to keep the drug concentration above the minimum inhibitory concentration for the bacteria throughout the interval. They're bacteriostatic, as we mentioned, but they're pretty cool because they're more broad spectrum than some of the other things we've talked about so far. So they get gram-positive and gram-negative aerobes. Their select anaerobes they're effective against, and they are typically the treatment of choice for rickettsial diseases, some mycoplasma, and leptospira in some cases as well. So these get these cool little intracellular organisms when we're talking about rickettsia, and these other weirdos that have different cell walls that would not typically be sensitive to beta-lactams and the things that we've seen so far. So a really great class of antimicrobial that you are definitely going to encounter in practice. The prototypes here are tetracycline, oxytetracycline, doxycycline, chlorotetracycline, and minocycline. And the main routes of administration are intravenously or sub-Q for oxytetracycline, and then orally
for doxycycline and minocycline. We do not use chlorotetracycline very often in veterinary medicine, but in some food-producing species we might use that. And I do think there's a mixture that gets like added to medicated feed. So the other route of administration here is ophthalmic preparations. And when we're talking about these IV and sub-Q forms and giving the oxytetracycline, at least when we're giving IV oxytet, we're always going to be diluting it out. And we'll talk about that in a minute on the toxicity page. So the main disposition here is that they're moderately lipophilic. They are amphoteric molecules, which is just describing their chemical makeup. And that means that they're really always ionized and active to be effective against bacteria. The problem is that there's a lot of protein binding in this class, so high protein binding just limits their availability as a free drug. And so when they're browned, right, when there's protein binding, they're not as effective against bacteria. So this particular class, even though it's moderately lipophilic, so good against getting through cell membranes, there is some degree of protein binding. And then for renal excretion or excretion in these drugs, we're talking about active drug is being excreted in the urine. So you do get high concentrations in the urine of something that's going to be effective against pathogens in your urinary tract. And there's also enterohepatic circulation that happens where the liver metabolizes some of this drug and then recycles some of the drug in your bile. So you get high concentrations of doxycycline and minocycline in the biliary tract as well. And that becomes really useful in cases of bacterial cholangiohepatitis, okay? So specific indications for these drugs include diseases where we have mycoplasma, rickettsia, lepto, or borrelia as your prime diagnosis. This is the drug of choice to treat Potomac horse fever, which is near Rickettsia ristici. And it's also one of the drugs of choice to treat Wolbachia in dogs with heartworm infections, okay? For toxicity, there's also a worry for nephrotoxicity in this particular class of drugs. These classic toxicities are definitely things that would be on boards for the tetracycline. So enamel hypoplasia given to young puppies and young growing animals can result in discolored teeth. Esophageal stricture when you give oral doxycycline, which is something that is reported most commonly in small animals, particularly cats. And then giving IV doxycycline is fatal in horses. So it is just a no-no, and it is something that is hard to do because there's not many IV preparations of doxycycline. But when that has been done in the past, it is invariably fatal. Horses will just drop off the needle. And then you can also have collapse with rapid IV administration of oxytetracycline. And that's the reason why it's so important when you're administering this intravenously to any species that it's diluted. Okay, so it needs to be diluted so it can be given slowly enough that you don't cause collapse. This drug, so the tetracyclines in general, tend to chelate with different divalent cations. So it can cause changes in your extracellular fluid calcium and can cause cardiac collapse, okay? Contraindications here again are the same in terms of the aminoglycosides. So dehydration, hypovolemia, renal injury, and insufficiency. Yes?
With the enterohepatic circulation, would you not ever worry about liver toxicity?
Yeah, that's a really good question. So whenever we have any of these drugs that need to undergo hepatic metabolism, then you definitely want to do monitoring to make sure the liver function is okay. A lot of the animals that have like an infection with, or like a primary liver infection, so cholangiohepatitis, they might not have overt liver failure. So there are going to be some drugs that have, that are metabolized by the liver that you might want to avoid, like metronidazole is like primarily metabolized by the liver. In this case, it's got some renal excretion as well, and so the drug, if it's not being metabolized fully by the liver, can also be metabolized and excreted renally. so we don't say we would never use this, but we would monitor liver function very carefully when we had a patient on a tetracycline that also we had worry about liver disease. So yeah, that's a really good question. And we'll come across that a couple other times because as the drugs get more lipophilic, hepatic metabolism has to occur, right? So really good. Okay, so in this class, we also have some unusual kind of mechanisms of action of the tetracyclines that are not always just antimicrobial in nature. And the main things that we see is that we can use oxytetracycline to actually treat flexural deformities or contracture in full, so contracted tendons. I don't know if you guys have ever seen some of our neonatal species, calves, foals, that kind of thing. They can come out with really contracted tendons, they can't stand up all the way, and that's a big problem for them to be able to nurse and grow appropriately. So in some of these cases, in young animals, we're able to give them a very large dose of IV oxytetracycline, but just once. So 50 mg per kg is like 5 to 5.5 times the dose that you would give for an antimicrobial use. And that with splinting, so with some mechanical kind of stretching of the limbs, can result in treating that flexural deformity. And again, it has an effect not only on how it kind of interacts with divalent cations, but also has effects on matrix metalloproteinases and can change how those tendons kind of interact with each other to let them get some laxity, okay? Doxycycline, also in particular, and probably minocycline as well, have anti-inflammatory properties, also through their effects on matrix metalloproteinases, and they are used sometimes in ophthalmology and dermatology, especially in things like melting corneal ulcers to try to stabilize and decrease the inflammation there. Whenever we're talking about using an antibiotic in some other use that's not specific to treat bacteria, we need to be careful about that because that could be a mechanism to promote resistance in the bacteria in that patient's environment just through exposure to the drug. So that's always something that we kind of consider, and clinically has not been reported to be a main driving feature or factor for resistance, but it's always something we should be thinking about. And honestly, using doxycycline and minocycline in ophthalmologic patients has really kind of fallen out of favor. Okay, so I'm going to leave you with two cases to kind of ponder for next time. So this is, these are both real cases. This is Chloe. She's 1.5 years doling, and she presented with bottle jaw and just feeling like absolute garbage, just really not wanting to eat anything. And her story was that she was being treated at home for respiratory disease for about 1.5 weeks before she came in. And she was getting treated with LA-200 for what they thought was an upper respiratory infection. And so had been getting that drug, and then had also found out through asking the owners that they had recently had a big oak tree come down after a storm. And so they fed all their goats all the branches from the oak tree, and it had all kinds of different fresh green leaves, some new little buds on there, and a lot of acorns. So this was something that they had not, I think there were 3 goats in the pasture, and none of them had really had that much access to acorns or oak before, but that was an important part of the history, and we're going to talk about what we have going on in this little goat in our next lecture. And then we have this other clinical conundrum to worry about as well. So you guys are going to have to think about a plan for this mare. But this is an absolutely enormous 9-year-old Percheron mare who had proximal enteritis, which means inflammation throughout the proximal portion of the GI tract. So she was essentially vomiting just constantly. 100 liters a day is what she was producing. She had evidence of pretty severe hemoconcentration. It was really hard to keep up with her losses. She's just absolutely enormous, and so getting enough fluids into her to replace what she was losing was a challenge. She was azotemic with a creatinine of 3, had evidence of tissue hypoperfusion, right? Lactate of 6. and was neutropenic and very leukopenic with a total white count of 3,100 cells, and 880 of which were neutrophils. So effectively neutropenic, really sick, and needs some sort of broad spectrum antimicrobial to protect her from getting a secondary bacterial complication. Okay? The main complications we see in these sort of sick patients are infections at the catheter site, so a septic jugular thrombophlebitis. She's got an indwelling nasogastric tube in, and she's just spewing gastric reflux from her tube 24/7. So we do always worry about them getting aspiration pneumonia as well. And then her GI tract is very inflamed. She could get a secondary peritonitis from translocation from that inflamed abnormal bacteria as well, or inflamed abnormal GI tract as well. So we need some sort of treatment for her. So you guys are going to think about what is the best choice of broad spectrum coverage in this particular case, knowing what's going on with her, what route of administration is going to be necessary, and we'll think about what happened to that little goat as well, okay? So you guys, thank you for your attention and being as interactive as you were, especially after you were just like minds were blown after your final, so I appreciate it.